to speak on surgery for gastric dilatation and volvulus. Let's give them a round of applause, please.
Thank you. All right, thank you, everybody. Let's do it. Okay, so we're going to talk about GDV. So yeah, I'll just ask the question: how many folks here are veterinary students? How many folks here are new graduates, like graduated vet school in the past 5 years? Okay, good. Okay. So I'm gonna try and, some of this stuff is gonna be fairly basic, but it's for the doctors, the vet students, and for the doctors who graduated recently. For those who are really experienced with GDV, bear with us, but it's gonna be good, hopefully a good learning tool for the folks who are a bit newer at this. So just some basic information on the prevalence of GDV. It's quite common. We see it 2.4 to 7.6 for every 1,000 dogs admitted to a hospital. 15% of dogs are dying of GDV in their lifetime. We do see a pretty wide range of lifetime risk, of course, breed-related genetics. They typically are middle age, or if it's a Great Dane, this is an older age, and there are large breed dogs with deep chests. And so you see these common breeds with GDV. The literature or the proceedings that you have for this talk have a lot more detail than we're going to go over here, just so you know. This is meant to be a very clinical review of GDV. So this is just a small sampling of risk factors. There is a long list of risk factors. Some are truly risk factors, some are probably just happenstance. It's difficult to say. But overall, the more common ones that we see, they're older dogs, what type of breed they are. If they eat a low number of meals per day, they are more prone to GDV. What's their temperament like? The more anxious or high-strung dogs, they may be more prone to GDV, which I tend to see in my experience as well. Being active after they eat, having a family history of GDV, having a history of splenectomy, and the thought there is that with removal of the spleen, there's increased room for the stomach to have mobility, and so maybe that's a predisposing factor. If they have a gastric foreign body, there are increased risk. There's an example there. Increased thoracic depth to width ratio and genetics. And that's just a small sampling of it. The idea here is that maybe something is wrong with the structures that attach the stomach to the surrounding tissues of the abdominal cavity, and that abnormality makes the stomach more mobile and more prone to either twisting and then bloating, or bloating and then twisting. We don't really know. So whether or not you have a bloat that starts first and then volvulus, or volvulus first and bloat, we don't really know. I do think that there's an acute or chronic component to this. I've seen dogs that I consider chronic bloaters, where they have a GDV, they walk into your practice, they're completely stable, they have a big stomach, you take your radiographs, and you're like, oh my goodness, it's got a GDV. And the dog is not acting abnormal at all. And I believe that some of these dogs, at least in my opinion, are chronic bloaters. They have a history of bloating, it self-resolves, they bloat again, it resolves. So there's something there. I've seen dogs in surgery that will literally try to re-bloat as I'm detoursing them and texting them. The stomach will start to fill up and try to re-bloat again. So I think there's something to this, but most of the cases that we see, of course, are going to be the acute GDV. And then I do believe that a lot of these dogs have a primary condition. We typically think of GDV as being idiopathic. And I think that the reason for that is we don't really work them up for other conditions, because they come in on an emergency. And then come out in emergency, easy to diagnose, you go to surgery and you fix them. And so I think that we consider them idiopathic because we don't really work them up. But I've seen dogs where, for example, have laryngeal paralysis and then they have a GDV. Well, maybe that neurophagia from the laryngeal paralysis predisposes them to bloat and then torsion, right? Or I've seen dogs that have lung tumors, or they have a liver tumor. Well, maybe those tumors are affecting the breathing pattern, the tidal volume, the respiration effort and rate, and that's causing them to become more aerophagic. I don't know, maybe. If there's a liver tumor, maybe it's displaced in the stomach in an abnormal position, and that's predisposing them to torsion. I don't know. But I do think we work these dogs up a bit more thoroughly. You might find a predisposing factor, or at least a concurrent morbidity that maybe has a relationship. I don't know. But I'm skeptical of calling this purely idiopathic. But anyway, currently we believe that's the case. Average rotation, 180 to 270 degrees along the long axis of the stomach, usually in a clockwise direction. The pylorus and duodenum displaces, ventrally and cranially from right to left. dorsal to the esophagus, and you get a sphincter obstruction and a pyloric dysfunction. And so this is your typical view when you go in surgery. You see the big stomach, the momentum over it. Maybe there's a hemoabdomen because of the short gastric vessel rupturing. Maybe the spleen is entrapped or ruptured, and so it's what you're end up seeing. And of course, it's a systemic disease. It's going to affect the entire body. And this is pretty much the standard chain of events that occurs, which eventually starts affecting the heart and these dogs. So it's a serious condition, of course, that requires immediate intervention. We're all familiar with the clinical signs: non-conductive retching, salivating, distended abdomen. And then for the newer doctors in the audience, this is just a recap on radiographs here. So this is a lateral radiograph. The head is over here, tail over here, and the idea here is the stomach axis. There's a normal axis to dogs and cats, and that axis is affected by how full the stomach is, what's the liver doing, what's the colon doing, what the surrounding structure is doing. And so when you have changes to the stomach, it's going to change the axis, right? And so let's say, for example, you have a large liver mass. Now the gastric axis is shifted, right? It's moved. If you have a small liver, the gastric axis shifts. And this is again for folks who are newer at veterinary medicine. You want to look at radiographs in this manner when you're evaluating the stomach. The other point that I want to make also is the gastric structure caudal to the stomach is always going to be transverse colon, always. So if you end up seeing some large gas-filled structure caudal to the stomach, it's transverse colon. That's the only thing that's there. And so to keep that in mind if you're a newer veterinarian, that when you read radiograph, the gastric axis matters. It tells you what's happening around the stomach and with the stomach and how it's shifting. And then the first gastric opacity after the stomach caudally is transverse colon. Keep that in mind. And then of course you have situations like this where you're wondering whether or not this is a GDV, and you're trying to, and again, lateral radiograph, head over here, tail over here. And if you can see the pylorus and the duodenum in a fairly normal position, unless it's going to be like a 360-degree GDV, which are really rare, it's probably just gastric bloat. And so we're trying to figure out, is this actually a GDV or not? This is your classic GDV. We could call it Popeye's arm, right? Or the double bubble sign, so 2 bubbles, and that's your classic GDV. Keep in mind also to always look at the entire radiograph, right? You're going to look at the spine as well. See the little spondylosis here? So the bridging spondylosis. It's an older dog. It's a large breed dog. It's got arthritis in the spine. This stuff matters. When you take it to the operating room and you put them on their back and you tie their legs, you are stretching out their spine. I've seen dogs that surgery went well, but now they have a T3, L3 myelopathy post-op because you stretch out the spine so much that you've now exacerbated the arthritis in their vertebral column. And so these things matter. We're all focused on the pool emergency part of it, but keep in mind there's other things to look out for. Look for pulmonary tumors. So you work these dogs up even though it's an emergency. Do they have a foreign body in the stomach? Maybe you have to perform a gastropexy and a gastrotomy. Watch out for these things. Here's again, severe diffuse spondylosis, severe intestinal ileus. All these things matter, and so if you're writing a radiograph as a new veterinarian, you want to make sure you know all of these things in the medical record. He's got multiple mineral opacities in the stomach. He's got GDV. He's got diffuse vertebral spondylosis and diffuse intestinal ileus, and that's your write-up for the radiograph. So just to emphasize being thorough when you're looking at these. You can also notice in a lot of these dogs may get esophagus. If there's a distal esophageal obstruction, right, then esophagitis occurs and you have a dilated esophagus. This is not neurologic necessarily. This is probably from esophagitis, and so there's a megaesophagus secondarily. Look out for these things. We're so focused on the GDV part that we forget to look at the entire radiograph. Another example here of just GDV. We've got the ileus, we've got spondylosis, we've got megaesophagus. So all these things are just to look out for, so just for the newer doctors. And these are just showing the different compartments that you're looking for with GDV, because sometimes GDV can be tricky to diagnose. So it's just another example here. On this area here, you'll notice that you might see a gas opacity abutting the diaphragm, remember the diaphragm. And so you're trying to figure out, you might be dealing with a perforated stomach or not. That's where pneumoperineum will sit. I'll show you images of pneumoperineum here soon. And this is for folks who've never seen a 3-view abdominal rather than GDV. Your typical view is a bilateral view. That's what you're aiming for. That's your standard view to diagnose it as quickly and reliably as possible. But if you're going to be thorough, I always recommend not just 2-view abdominal rads, 3-view abdominal rads. And again, you have to use your common sense, your clinical judgment. If the patient is super critical, and you just want to diagnose the condition and then stabilize and talk to the pet owner, you need a right lateral radiograph. But if you're going to work the pet up effectively, 3-view abdominal rads, and for those who have not seen a GDV on the other views, this is what it typically will look like. So now pneumoperitoneum. This could be a tricky one to diagnose. This is a very straightforward one. You can see all the organs quite clearly. The air is outlining the viscera very nicely, and so this is an obvious pneumoperitoneum for whatever reason. This could be GDV or a foreign body or whatever. It doesn't matter. But I just want you to be exposed to pneumoperitoneum. But pneumoperitoneum can be quite tricky as well. The first place air is going to typically accumulate in a pneumoperitoneum is going to be right by the diaphragmatic crurum, right by the crus. You'll see the diaphragm, the thin muscle diaphragm, nicely outlined, and there's air here. That's difficult to say because you have the lungs silhouetting. You might have an enlarged stomach that's silhouetting, so it's tough. But if you see the stomach is way over here, and you've got this thin diaphragm here that's outlined, very suspicious for pneumoperitoneum. Put it together with the history and the clinical signs, of course. But there are things that you don't necessarily want to miss. So take a look at that. That's where air is going to show up first on a lateral radiograph for pneumoperitoneum case. And then finally, mesenteric torsion, just another example of a torsion. You might see something like this: severe intestinal dilation with gas. It's taking up the entire abdomen. Torsion is not common at all for the intestines. Mesenteric, but just want you to have exposure to it. And then there's all ventrodorsal radiographs of the GDV. And then sometimes you unfortunately are working up a dog and you don't know what's wrong with it, and it goes to CT scan, and then you find on CT scan it's got a GDV. That happens. And so here's an example of a transverse view of a CT scan, gallbladder, esophagus, duodenum, a huge stomach, and then here's a coronal view, huge stomach, and so, whoops, GDV on the CT scan. And so I mentioned all this stuff with the new graduates because we do have a telemetry program for VetTriage Pro. Folks are interested, feel free to contact me. But we partner with hospitals to help with new graduates work up cases. And so if you're a new graduate and you want mentorship, we have virtual veterinarians that work for my company that'll help. And so I'm going to bypass all of this. We talked about this yesterday in the telehealth talks. And so this is an example of one of my doctors, Dr. Schultz. He's helping a new graduate talk about a TBLO. But telementoring is really important, especially these days where vet students are graduating, getting their first job. They don't have mentorship. They get their first GDV. They don't know what to do, and they're alone. And so I offer virtual telementoring where you talk to a seasoned veterinarian about a case, and they'll help talk you through it. So for those new grads in the room, those who are not experienced, or maybe those who are experienced but want to run a case by a seasoned doctor just to get their opinion on it without talking to a specialist, we've got VetTriage Pro for telementoring. Just keep that in mind. If anybody's interested, you can, of course, reach out to me. And the other thing I want to talk about for the new graduates and for the less experienced veterinarians is communication with clients. Because you have a GDV, it's going to be high emotion, right? The pet owners are freaking out. It's your first GDV. The dog is critical. You're trying to get all these things in your head, and you're trying to communicate with the pet owner, give them confidence in you, and also be able to work the case up as quickly as possible. And so let's talk a little bit about communication. A lot of it is nonverbal. Your tone in the room, your mannerisms, what your hands are doing, where you're looking, the vibe in that room matters a lot to people. They can sense all of that. And yes, verbal, of course, is very important, but nonverbal is quite vital to communicating with pet owners. And so I talk about this all the time to interns and vet students about how to communicate. If you look at a scenario like this where you've got a dog on the table and you look up at the pet owner, the pet owner's focused on the dog's trying to get off the table, you're trying to do your job with the doctor. This is a weird position to be in. You may want to modify the way you are talking to the client. Maybe you want to be side by side with them, showing that you're equal. And you're not opposite the client, you're not opposite them, you are side by side with them. So you're next to each other. Now you're a team, and you're both discussing the pet. But you still have the dog on the table, and the dog is trying to get off the table, and the pet owner is kind of listening to you, but not really, because they're focusing on the dog getting off the table. So maybe you want to sit down with the dog, and then both of you are in a more comfortable position, but you're still across from the client. It kind of gives this interview style, which, you lose some of the humanity behind it. Maybe you want to be side by side. So you're both sitting, the dog is comfortable on the floor, you're talking, you're on the same side, you're a team, and this is really helpful to kind of keep the temperature down when you're talking to a pet owner in the exam room about a critical case. So these are things for the newer veterinarian to keep in mind when you're talking about something critical. And then even better, you know what? If you get down below eye level to the pet owner, you know, so now you're not this dominant, you know, presence in the room. You are showing submission, right? You want to be the friend of the pet owner. You're not looking to command things of them. You want to be their friend, and so you sit next to them or you kneel down next to them. This I love. You're on the same side with them. Dogs on the floor. You're kneeling down, right? You're showing subservience to the client. It's a nice way of cultivating a warm environment in the exam room. So keep that in mind for those who are a bit newer at this. These types of things matter. And then when you talk about a case like a GDV or anything severe, hemoabdomen or a blocked cat or animal that's in respiratory distress, remember to not judge the client. They're trying to make decisions based on their own culture, ethnicity, finances, their pet, you know, their family, right? And so perspective taking and seeking also require us to draw upon cultural humility and recognize that our clients view their patients' care journeys through a unique lens. They may be influenced by personal, familial, cultural, and societal perspectives on the relationships with animals, the function and inherent value of the individual patient, as well as the uniqueness of their bond. This is basically saying your job as a veterinarian is to give them the options, the pros and cons of each option, and let them decide using their own life decision making to tell you what they want to do. Maybe their decision is not what you would want to do with your pet, but it's what they want to do with their pet, and they're doing it informed because you informed them of all the options and pros and cons. So keep that in mind. Now, some things like GDV, it's pretty clear cut. You're either going to go to surgery or unfortunately have to euthanize. There's no way to really, you can't really detours them and then send them home. They're going to tours again. And so there's some that are clear cut. But a lot of our cases have a lot of options, and from really great options to pretty crappy options and everything in between. And you give the clients the pros and cons and let them decide. So it's part of the whole spectrum of care. We won't go into this in too much detail when we get back to GDV. So, treatment. Now, you have levels of treatment. You're dealing with any critical case, whether it's GDV or something else. And so as a surgeon, this is sort of how I think about it. And these levels here, the red, the orange, the green, there's going to be overlap, and you're going to go back and forth. But essentially, with critical cases, GDV or otherwise, you're placing a catheter, you're running some blood work, collecting radiographs, doing some vital checks, but you also have to do all of this with consent of the pet owner. You can't just start treating things and diagnosing stuff without talking to the pet owner first and getting their permission. They have to sign off on estimates. So you're doing all the stabilization, you're talking to the pet owner, you're getting authorization from them, telling them what things cost and what you think is going on. You run some diagnostics, you get some more answers, you go back to the client, you communicate with them, go back to the patient, run some more diagnostics or fluids or whatever it's going to be, and then you're sort of in phase one. And then phase two in the GDV, you're getting ready for surgery, so you continuously stabilize them, getting them ready for the operating room, getting ready for your anesthesia, prepping the operating room, getting your surgical team together or whatever team you have at the hospital, and then of course you're going into surgery. You are constantly stabilizing the patient, going back and forth, and then post-operative recovery and from there. And so we're going to talk about post-operative recovery here in a minute, but this is typically the stages that you're going through back and forth, back and forth. It's all touch and go, right? The pet owner in the room, they're crying and they're stressed out, and you're trying to stabilize the pet. And then of course keep in mind that other appointments and other things happen in the hospital. So these are typically the steps that I think about with the critical cases. Now, stabilization is a whole other topic that we can talk about if folks have questions, but essentially you're trying to get at least one, if not two large bore IV catheters and then fluid bolstering, right? You're trying to dilate the hemovascular system, right? You're trying to stabilize them, get the blood pressure up, get the heart rate down. You're trying to stabilize them while you're also trying to perform gastric decompression. How many folks here with their GDVs, do they trocarize them? How many folks trocarize? Yeah. Some do. I usually don't. My goal really is to get them, again, I'm a surgeon, so I'm on call, and so I go in and they're going to intubate and pass a tube. And so I have the luxury of having a full team. But if you're alone doing this and you don't really have the ability to rush right into tubing the dogs, then trocarization in the literature does work, and folks have experience with it. It seems to work. So that is an option there. I don't believe that if you were to trocarize them, you're at increased risk of perforating the stomach. If the stomach is devitalized, meaning it's already necrotic, that's probably when it's going to perf, but the stomach was necrotic to begin with. And so if you go in surgically, whether you perfed it or not, at this point, probably doesn't matter. You have to take care of a gastric necrosis in surgery anyway. So I'm not sure I'm very worried about that. If you like localization, go for it. I don't see it as being a risk of perforating. It's similar to like blocked cats. If you're going to perforate the urethra with a blocked cat, probably that urethra may have been already compromised really bad, and so it didn't take much to rupture it. But that's how I look at it. But anyway, so that's what that is. But you're going to stabilize them however you can, whether it's blood products or colloids. You're trying to stabilize the patient, and then of course you want to pass the gastric tube. Some animals are so abundant, they're so critical that you can pass an oral gastric tube through while they're awake, because they're just so out of it. And so you can put a medical tape in their mouth so nobody gets bit, so they don't bite the tube, and then pass the tube through that if they're so moribund that you can just do this. Otherwise, most dogs have to be sedated to pass an orogastric tube, in which case that's what you're going to do. I tend to do this either pre-operatively or I'll do it intra-op. I'm literally cutting the dog while my surgery technician is passing the tube. Just depends on how you're set up. You want of course, you can pass them as quickly as possible. For me, I'm trying to do all the things at once and get them out of the surgery quickly. So they're gonna tube them and try and decompress the stomach, either right immediately pre-op or intra-op. And this is a video just showing how the torsion goes. Because obviously during surgery it's going to be a mess. You have all this momentum, and so you want to try and plan out what you're going to do with detorsing them. And so if you look at this and you're trying to reverse it, let me see here. You're trying to reverse it. You're trying to grab the pylorus, right? So it's going to go over. So it's going to go over. There you go. So you're in surgery now. So what I'm going to do is I'm going to grab the pylorus, usually with my right hand. I'm a right-handed surgeon. Mostly I'm standing on this side of the dog. This is the left side of the dog, right side of the dog, head up here, tail here. There's the pylorus. I'm trying to search for the pylorus. I'm trying to grab it. And then while I'm grabbing the pylorus with my right hand, with my left hand, I'm pushing down on the dilated portion of the stomach. So grab the pylorus with right hand, push down on the dilated portion of the stomach, and towards it. And if that works, you'll end up hearing the gas escape the oral cavity. The stomach will decompress, it'll deflate, and then have a flaccid stomach that you can now take your time and pexing. So that's typically the way it goes. This of course can vary depending on the degree of rotation, but typically it's 180 to 270 degrees. So you're trying to, a lot of times blindly find the pylorus, grab it with your right hand, push down the stomach, and then detours. And then you'll get that release of gas. And you'll know that because sometimes what will happen is if you're trying to pass the tube and it can't go, right? What I'll do is I'll have the technician passing the tube gently put pressure, and after putting pressure on the distal esophageal sphincter, I'm trying to find the pylorus and pushing the stomach, and then once I release it, once I get towards it, the tube will then pass. And so that's why I know that everything's in anatomic position and that the tube is passed, and so we can continue with gastric lavage and then pexing. So surgery, this is the basic anatomy. You might have a hemoabdomen due to short gastric vessel rupture. The spleen may or may not be compromised. You may have a splenic infarct, in which case you're palpating the vessel and spleen and you don't feel pulses, so spleen may have to be removed. If you don't remove the spleen and it should have been removed, you risk having splenitis and then a splenic abscess post-operatively at some point. And so the spleen is questionable, or you're just not really sure. What you can do is either you can do the splenectomy, or if you want to, you can leave the spleen alone, do the pexy, and then go back to the spleen and then decide if you want to remove it or not. And if you're going to remove the spleen, always biopsy it. Submit it for biopsy. These are the same dogs that get hemangiosarcoma. They're the age, they're breed for it. Biopsy the spleen, and the whole thing in. Now, if finances are a problem, and you can't afford everything, then again, you'd rather save the dog's life and throw the spleen away. But if finances are not a problem, submit the spleen for a biopsy. You never know. You never know. Also, as a rule for me, liver biopsy in these dogs. We have liver here, I don't know. Always liver biopsy. Because they have the same breeds that get hemangiosarcoma, or cancer in general. And so I get a liver biopsy, and I submit that as well. That's what I do for all these cases. Again, assuming that the client can afford it. And then, of course, you can have a very scary-looking stomach where it looks really, really bad. There's a focal area that looks really bad, and you're not sure what to do about this. So if you're pretty sure that this is necrotic, so it feels thin, has no pulses, the color is abnormal, usually it's like really flaccid, thin wall is kind of pouch, then you have to either remove it or invagginate. And both surgeries suck. They're not good. And I don't have a lot of dogs that have survived gastric resection or invagination. They just don't do well. And so I do know some surgeons that will cut these dogs, they'll see the necrotic stomach, they'll leave it alone, they'll peck the dog, and like 2 or 3 days later, they'll re-explore the dog with the stomach again. And they've noticed maybe sometimes the stomach resolves. I don't know. That's not published data. That's just from talking to other surgeons. So it's something to consider. But the prognosis for these dogs with gastric resection is so bad that I'm almost happy to try that. But you have to have the right owner, the finances, and realize that that's kind of an experimental thing. But anyway, you want to look at the stomach and make sure that you are happy with what it looks like, and if not, deal with it there. And then I want to stress here valve floor retractors. Valve floor retractors. They're important for spays, for abdominal exploratories of any kind. Valve floors, they're great. You don't have to struggle in surgery. You buy valve floors and do a lot of abdominal surgery, especially if you spay a lot of large breed dogs. I find that general practitioners don't have valve floors and they're struggling with the large dog spay. They can't see the pedicles. Get valve floor retractors. They're well worth the money to do a lot of abdominal surgeries. And then we know there's different types of gastropexies. Typically I'm performing the incisional gastropexy. In the proceedings I have all the comparisons of the different types, but depending on what your comfort level is, you've got a number of options there. And of course for dogs for prophylactic gastropexy, you can perform a scope if you're comfortable with that sort of thing, or you can refer them to a surgeon. You can have the dog spayed and neutered at the same time. You get a pexy done, the beautiful looking pexy, prophylactic for the right owner and the right breed. So gastropexy is for emergency treatment. Gastric derotation, abdominal exploratory, can be preventative or can be a treatment, depending on what you're dealing with. There's a nice looking incisional gastropexy here. You want an incision that's some centimeters in length. You want to be away from the pylorus. Average surgery time in the literature is about 1 hour. I mean, I've done these in 15, 20 minutes, and I'm sure lots of surgeons here that have done these routinely are quite fast with these surgeries. But I can offer some tricks to this. What I typically will do is if you're dealing with the gastropexy here, so the dog's head will be over here. So this is the left side of the dog, here's the right side, and you make your incision at abdominal wall, make the incision, matching incision with the stomach. I am going to suture the deep portion of the pexy first, the deep portion, right? So the portion is deep to me, and I'm going to start cranially. That's going to be where the deepest point of the abdominal cavity is. And so I start the pexy cranially and at the deep portion, and I do the pexy, boom, boom, boom. And then for the superficial layer, I start cranially and go caudally and do the superficial layer. And that's superficial meaning closest to me. And so that's a nice trick. Otherwise, if you do it the other way around, you're going to be working in a dark hole and fighting the organs, and it's not worth it. I typically use zero proline for these, but I know surgeons that will use like zero PDS, something absorbable. I use permanent suture, but it's up to you. Both work really well. And then another trick that I have is, as a surgeon who's on call, and I'll only have to be a surgery technician and they're doing anesthesia, I'm the only one in the OR. I will take towel clamps and I'll place towel clamps on the linea, the abdominal wall, and I'll hold that up with one hand, and then I'm suturing the pexy with the other hand. And so what I'll try to do with these cases is I preloaded the needle holders with my suture. If you have the luxury of having cardiovascular pack with really long needle holders, that makes it even easier, but you don't need that. You can preload your needle holders with the suture, and then I'm ready to roll. I've got the towel clamp on the linea here, and so with my non-dominant hand, I'm holding the abdominal wall up, and then with my dominant hand, I'm doing the pexy. And so that allows me to do the pexy alone without an assistant. Otherwise, if you have an assistant, they can hold the wall for you, they can retract all the organs, and you're working in a nice space. But if you're by yourself, this is a pretty cool technique. This does not go on the skin, this goes on the linea alba, not on the skin. This is just the linea alba. And you're holding it up and then operating that way. And the other thing too, this is the point where you probably want to take the valve floor retractors out. The valve floor retractors are going to not only, they're going to skew the anatomy, So you don't have, it'll distort this also, but it's going to make it a lot more difficult. You're going to be fighting the valve for retractors. So when I'm all set with my abdominal exploratory, I remove the valve for retractors, perform the PECC, and then move forward from there. Complications. Overall, 76%. That is high, but it shows you that this is a disease that affects the entire body. Complications can be anything from pancreatitis to arrhythmias to incision infection. So it's a wide array of possible complications. But more specifically, renal injury in these dogs, coagulopathy, arrhythmias, thrombosis, peritonitis. These are things you talk to the pet owner about. You warn them about gastric resection, you warn them about splenectomy, you warn them about cardiac arrhythmias, right? They have to understand this is a systemic disease that can affect multiple organs. But also you're trying to get into the operating room, and so you want to talk to the pet owners thoroughly, but also go into surgery. I mentioned pneumonia because a lot of these dogs are older dogs. You have a large, maybe overweight, obese, large breed dog, old, and arthritic, and after surgery they're going to be recumbent, especially if they're on lidocaine for the cardiac arrhythmias. And so a recumbent dog is prone to bronchopneumonia. And so they're just laying there in their cage, latterly recumbent, and the dependent lung is going to be more prone to developing pneumonia. So you want to get these dogs up and moving, or maybe just rotate them at least if they're not moving right away. You don't want them to run around because they're critical, but you want to get them up and moving so they don't develop bronchopneumonia, and also so you can avoid pulmonary thromboembolism as well. Mortality, 10 to 68%. It's a huge range because this disease is very complex. But survival overall is pretty good. And then with no surgery, 80% are going to recur, 80% are going to die within a year. So surgery is the treatment of choice here. How they present to you, if they present to you in a coma or recumbent, they have a higher risk of not doing well. And all these factors and more are in your proceedings as well, just so you know. There's only a few of them that I'm mentioning. Splenectomy, 40%, gastric necrosis. I mean, just a really terrible recovery with gastric necrosis. Lactate and other biomarkers all play a role with this disease. And then, of course, to revisit this again, you're going to continuously reevaluate the patient, talk to the client, reevaluate, run diagnostics, talk to the client. It's a back and forth dance. You can have a perfect surgery that can be ruined with poor post-operative care. So if you're going to perform gastropexy, if you're new to this, or maybe you don't have an emergency hospital that you can refer to post-operatively, you have to take care of the pet in your clinic. And you may not have 24-hour care in your clinic. You may not have all the fancy stuff, all the tools to evaluate them, to monitor them. So, my bare bones post-op recovery for these dogs, you want to have an electrocardiogram, monitor their heart. Maybe it's spot checking every 6 hours, or ideally continuous. ECG monitoring. You're going to check their TPR, so temperature, pulse, respiration. You're going to weigh them once or twice a day. Have them on a respiratory watch because they're critical. Watch for regurgitation. Walk them at least every 6 hours. Try to get them up and going outside so you don't have pneumonia or PTE. And if they're too weak, then put them on a gurney outside, put them on the floor, let them smell the air, breathe pee and poop, get them back in the gurney and roll them inside. If that's not an option, have them walk around ICU then. But do some, or you're back in the hospital, the prep room. Whatever you have to do to get them up and moving a little bit. Have an e-collar on so they don't look at the incision, blood pressure checks, of course, and then every time you're diagnosing hypo or hypertension, you're going to intervene, and then reaching the blood pressure afterwards. You don't check the blood pressure, realize it's abnormal, treat them, and then don't check again. You have to go back and check the blood pressure again. And then look for any other abnormalities in the blood work or parameters. Typically, my antibiotic of choice is going to be cefazolin, injectable until they're eating, then cephalexin. But you have to use your judgment. They have comorbidities. Maybe they need something stronger and more broad spectrum. They're going to be in IV fluids, at least until their cardiovascular parameters normalize, and ideally probably until they're eating and drinking and holding food down. That would be ideal. You're going to use colloids if you need to for blood pressure, in addition to their fluids, or even blood products, depending on what the case needs. And then we're going to talk about cardiac drugs. So in general, actually we'll go to the next slide and I'll show you my idea with this. So anyways, cardiac drugs if you need them, antiarrhythmics, antacids, anti-nausea, motility drugs, pain medication, anything else that they have to be treated with if it makes sense, and then treat any abnormalities with them. Let me see if I have, okay, so let me go back to this. Okay, so my rule in general with treating for cardiac arrhythmias. So first of all, I usually have the benefit of having internal medicine in the same building. So if I don't know what the arrhythmia is, I ask them and they tell me the answer. But let's say we know it's some sort of ventricular arrhythmia. When do you treat those? There's two scenarios where I'm treating ventricular arrhythmias in dogs, whether it's GDV or hemoabdomen or anything else. One is they're clinical for it. Clinical meaning they're collapsing, they have pale gums, they have dropped pulses. Those are cases where I'm going to treat them for the arrhythmia regardless of how bad it looks like on an ECG. The second scenario is if they have a sufficient percentage of their ECG is arrhythmia, then I treat them. The cutoff is typically 25 to 30%. So if I do a strip of ECG and 25 to 30% of the rhythm is ventricular, then I'm going to treat. Less than that, and they're not clinical for it, I probably am just going to monitor. But if they have at least 25 or 30% of their strip is arrhythmia, and or they are clinical for the arrhythmia, then I treat. And my treatment regimen is usually a bolus of lidocaine and then a CRI of lidocaine, and I start them at the same time with procainamide, typically injectable, IM, I think QID, and then when they can eat, then they're on oral drugs. The goal here is to eventually get them off of the lidocaine. You don't have to wean off lidocaine. People do, I've done it too, but you don't have to. But lidocaine, the problem with it is it causes neuromuscular weakness, it causes nausea. So it slows down the gastrointestinal tract, they don't want to eat, and because they're already old arthritic dogs, now you're making the neuromuscular weak from lidocaine, it does an analgesic, and so I want to get them off that as quickly as possible, but not at the risk of the heart. So I start the procainamide at the same time so we can start to get that in the body, injectable, and then they're on lidocaine, and then whenever I can get them off, I get them off of lidocaine. And they usually go home with 2 weeks of procainamide. I recheck the ECG at the recheck, which I know is just a spot check. We don't know if the arrhythmia is before or after that spot check, but most pets are not showing clinical signs at home. I do a spot check at the recheck, and then I decide if we're going to continue this or if we're going to stop it. And again, if I'm not sure, I talk to internal medicine, but in general, that's my guideline for how to manage arrhythmias. Okay, key points. Prevention, of course, is ideal. I do think, obviously, acute is what we typically see, but don't forget, I do think there's a chronic component. I don't know, but I've seen this enough where I'm convinced that at least some of these dogs are chronic. I'm not as convinced they're all idiopathic. I do believe that some of them have a primary cause. We need to do a better job working them up. Gastric resection, do you delay it or not? I don't know, it's just a thought. And then always biopsy the spleen if you remove it. Always biopsy liver, even if it looks normal. And then concurrent surgical procedures. If a client says, hey, by the way, can you remove that fatty mass? Can you remove that mammary gland? I'll tell them yes, but I have the ability to abort mission. If I think the patient is not doing well under anesthesia, I'm not going to do that cystotomy or that mammary gland removal. The GDV comes first. That's the most important thing. But if I can't do them at the same time under the same anesthesia, it's better for the pet. It's one anesthetic episode, better financially for the client, but I'm not going to risk the patient's life for the GDV just because you wanted to save some money on the life removal, right? And so I'm going to get the permission ahead of time that I can afford that plan if I want to. So frequently for these dogs, they have concurrent issues, and that's why I deal with concurrent surgical procedures if the client inquires about it. And then, of course, a reminder, we have Veterinary Pro for those who want telementoring for cases. And that's it. This is my contact information. If you want to learn more about my company, it's Veterinary. Feel free to reach out to me. I have videos on YouTube that for educational purposes, for those who want it. My email. And thank you for watching. And any questions, I'm happy to take them on.
Thank you so much. There are some questions on the chat. So
Sure.
the first one is about splenectomies. Do you always do routine gastropexy if you have to do a splenectomy, especially in large dogs?
Oh yeah, okay, great question. So I really can't. So if you have a splenectomy, whether it's unstable, so hemoabdomen, right? So you're doing the splenectomy right then and there. Do you PEX them at the same time or not? So it's the same conversation I have with any other ancillary procedure. I tell the pet owner, if the pet is stable enough for me to PEX them, I will PEX them. If not, we're not going to do it. And I do realize, as I mentioned, that splenectomy increases their chance of a GDV, right? The client has to know that. But I'm not going to risk the patient dying from GDV because I spent too much time on the PEXI. So I tell them that exact thing. I will do it if the patient is stable enough to handle it. Otherwise, we can PEX them later on, but I'm not going to do it if I think the patient isn't doing well under anesthesia. So that's why I do that open. Yeah.
The next question is on considerations for pricing. when we do these kinds of surgeries, especially given the fact that the success rate is always very variable. A lot of things can happen post-surgery. Yeah, what are some of the approaches or recommendations you have?
So this is tricky. Great question. So I find a lot of my interns that they'll put everything on the estimate, everything in their blood and plasma and biopsies and everything else. And to some degree, I understand that because you want to cover your bases, but you also might end up euthanizing an animal for financial reasons because your estimate was too high, and maybe it didn't have to be that high. But you also don't want to underball the client either, right? They sign up for a relatively cheap surgery, and then they go home 3 days later with a very large bill. So client communication is important. So what I do with these clients is, if I can make a judgment call ahead of time and say, if I can predict what this patient needs right now, from what I can tell, it doesn't need a blood transfusion right now, I don't know about the spleen, I'm going to estimate for what I know this dog needs, and assuming no surprises happen, this is going to be the price, give or take. However, if I go into surgery and I find out I have to remove the spleen, or I have to do a gastric resection that's going to cost more money, and I know this client has financial concerns, I might call them in surgery and say, hey, the spleen has to be removed. I'm in surgery right now. You're on speakerphone. I have to remove the spleen. It's going to cost another $1,000, whatever, to remove the spleen. Are you okay with that? And they tell me yes or no. And then you deal with it from there. So it might be more, but my way of handling this is dynamic, right? As things go on, I communicate with the pet owner about what has to be done. And that's why I tackle these. It's sad to see a dog euthanized because of finances that were overestimated, but you also don't want to lie to the client. You need to be ethical about it. And so I give them what I think the dog needs, warn them that this could change as this disease progresses, and then I communicate with them from there. It's annoying to do it that way, but I think it's the right way to do it for dynamic procedures like this.
Okay, the next question is about anesthetic protocols. Any considerations, anything that we need to watch out for with anesthesia in these type of patients?
Yeah, so I am spoiled in that I have other people doing anesthesia for me, and so whatever protocol they want, I typically agree with. If there's anything that they have questions about, I tackle it. So typically, with these dogs, I feel as though less is more. Remember, they're old dogs, and sometimes they have comorbidities. So a standard dose of hypermorphone may be really too much for them. So you want to titrate things to effect. But it's going to be your typical pre-medication with whatever your choice is, and then induce them, and then gas anesthesia from there. Beyond that, I don't have much else to offer, unfortunately. I'm a bit spoiled with the technicians that are awesome, and they do the anesthetic plans for me.
The next question is about dogs that are arthritic and maybe already have spondylosis. Do you usually go ahead and do the surgeries, especially if they're quite advanced, or would you already from the start just kind of recommend that they use animal thinking?
So the presence of comorbidities for a disease that's acutely life-threatening is not a reason for me not to do the surgery. I'm going to do the surgery. I'm going to modify things around them. So for example, if this dog has really arthritic joints and spine, I maybe won't tie their legs on the operating room. I'll just let their legs hang, or maybe tie it very loosely, right? I'll put more padding on them, underneath them, things like that. If the pet owner understands this dog is old, but this is also an old dog disease, middle-aged old dog disease, and it could go either way, and because of the age, we don't know how things are going to go. When they understand all that stuff, then I'm going to do the surgery and deal with the sequelae afterwards. For me, it's not a reason not to do the procedure. I also have seen surgeons put these dogs on non-steroidal anti-inflammatories post-op because their spine and their arthritis, and of course, the inflammation involved. I'm not sure I'm a fan of that. I think that any gastric surgery or gastrointestinal surgery, I'm avoiding NSAIDs. But I have known surgeons that have done it without any problem. So I don't know what the consensus is on that, but it's another thing that I try to avoid with these patients if I can. I'm going to try to use injectable narcotics, opioids, and then when I give them an oral drug, it's going to be Tramadol, gabapentin, combination of those, and I'm going to try to avoid NSAIDs. But it may not be wrong to do NSAIDs, I just don't do them myself.
There is one more question. Just a reminder for everybody in the room, you can ask your question via the app, and alternatively, if you want to ask your question in person, you can come to the middle of the room and ask your question. I think we've got room for at least 2 more this morning. The next question is about your priorities in terms of abdominal radiographs versus traumatization. I'm guessing this is more in the setting where there's a solo vet. What should they prioritize?
Yeah. So I unfortunately come from very litigious areas. I worked in New York and in California, and there's a lot of blame going around. So I want to diagnose the condition first. So I'm going to get my radiograph first. It's unlikely in my mind that those couple of minutes to get the right lateral radiograph to confirm the condition is going to matter for that dog. And so now the dog comes in for resting, and you have to perform CPR. That's different. You have to do life-saving measure. If the dog is alive though, and they've got a GDB and they're sick, get them in the radiograph, get them to radiology, collect the right lateral view, just get the one view for now, confirm the condition, go to the pet owner, and talk to them. Also legally, I don't perform procedures on dogs unless I have the permission of the pet owner first. I want them to acknowledge that I have permission to do it. I don't even cut the dog's nails for a nail trim that the owner is saying it's okay doing it. Because I've had clients complain that we cut the dog's nails without their permission. So for me, the order of events is to diagnose the condition first. You just need one right lateral radiograph. Go talk to the pet owner. He's got this condition. I have to do A, B, and C right now. If I can do that, sign this paperwork, I'll come back in a few minutes once I'm done. And then go save the dog's life, come back. Okay, Fluffy's doing X, Y, and Z now. I'm gonna run blood work now. I'm gonna do some more x-rays. Are you okay with that? We're gonna do surgery tonight. Back and forth, back and forth. So diagnose it first before intervening. It puts you at legal risk to perform procedures on an animal. That's the owner's permission first. Even CPR, you get permission first, right? The dog comes in, a critical, it's no heartbeat, not breathing, right? You're still saying, can I do CPR? And then get yes, and then go.
Okay, are there any questions from the floor? Okay, there is. Yeah, please step up to the mic.
Sobre a anestesia, o senhor não comentou sobre essa disciplina. Faz uso, tem recomendação, que eu aprendi que eles vão fazer um preventivo.
Can I ask why do you use N-acetylcysteine in these cases? What's the reason?
Seja a anestesia, também uma inflamatória para a intestino.
Transition. Okay. So the question is, do you ever? Thank you. The question is, do you ever use N-acetylcysteine preoperatively? I have not. The only time I've ever used N-acetylcysteine is if I have a very cephalic dog that I'm having issues with bronchodilation. I've used it as antioxidants or for oxidative injury and to help with bronchodilation. But that was like 2 cases in my 20 years. So no, I have no other experience with it. When I read about N-acetylcysteine in the past, it seemed very, very useful. It also seems to be, for some reason, at least in my practice, is very expensive. But no, I have not used it before. Has anybody else used it preoperatively for cases? Yeah, I have not. Are you happy with the result? Do you find that it helps?
Could you please step up to the mic because the sessions are being recorded. Sorry.
Back and forth.
Eu aprendi assim, então acabou todas as vezes eu usei e deu bons resultados na cirurgia. Então não sei se esse aqui fez a diferença realmente, mas as cirurgias que eu caracterizei que eu usei, eu posso dar uma coisa melhor. Não sei se esse aqui fez a diferença.
Okay, again, so you can post-operative period may have helped them, but I'm unsure if it made a difference. What I'll do, so yeah, thank you for that. I'll have to research it and see what the literature is on and go from there, because I have no experience with it. Thank you.
Yeah, please step up to the mic. This will be our last question because we have only 2 minutes after this session.
I might be missing because it's the first part, but do you use lactate as a parameter for prognosis?
Yeah. Yes. The question. The question is, do you use lactate for prognosis? Yes. Well, yes and no. So I mentioned, where is it? Here, I mentioned here lactate concentrations. And the reason why I mentioned it here and I kind of glossed over it is because the literature is all over the place with this. It depends how you're measuring lactate. Are you comparing pre and post-op, initial lactate versus initial lactate versus lactate they end up with post-operatively, all this stuff. So there's a lot of details. So yes, in the literature it matters a lot. Clinically, I don't really care. Because for me, the same treatment is going to happen regardless. I'm going to stabilize the dogs with fluid expansion and then go to surgery. I don't even measure lactate after the fact. I have it preoperatively because it's part of the panel, but to me it doesn't really matter. Having said that, high lactate is correlated with poor prognosis as well as the higher incidence of gastric necrosis. And so it does matter. But clinically for me, I'm going to do the same thing anyway, and I'm going to tell the pet owner, hey look, the lactate is this, the cutoff literature is less than this, should be euthanized. It doesn't make any sense to me clinically, but yes, in the literature, it's all over the place. In fact, in the proceedings, I have lots of different biomarkers that are in the literature that look at the same thing for these dogs, myoglobin and other factors. Things we don't routinely check are all considered. So yes, it is important. It doesn't add into my conversation with the pet owner. Yeah.
Awesome. Thank you so much, everybody, for attending. We've come to the end of the session. Please join us again after lunch for more soft tissue surgery. And thank you so much to Dr.